All right, welcome everyone. I'd like to say thank you to our presenters who are here today. We have Mitchell Tepper. I'll let you introduce yourselves when it's your turn, and Katrina Nicandri and Danielle Shapuk. Danielle is not quite here yet, so we're hoping that she pops in shortly. Feel free to ask questions at the end of each of their presentations, and we look forward to a very informative and answering questions we've all had and we're too afraid to ask. So with that, there is the interpretation button at the bottom. People will be checking in on that and selecting their language of choice. And with that, I hand it over to you. So Katrina, if you would like to go first.
All right, let me get here so I can share my screen. All right. Where is it here? Sorry, I have two screens working, so I'm trying to figure out the navigation of both of the screens here. All right. And it's supposed to be slideshow. I did this morning too, so when you know, it's supposed to go from beginning. What am I doing? All right. And let's see. One more second, sorry, bear with me, I apologize. I share screen and this one. Share, all right. I think we are all there now. Sorry about that. Me and technology, my husband's the technology guy in the house, so.
I have the same issue. It's all good. Thank you. It's good.
So today I wanted to talk about periods, birth control and beyond for women with developmental disabilities. Some learning objectives today, the impact of puberty on adolescent girls with disability and their families, understanding some medical and ethical issues around menstrual suppression, cyclical hormonal changes and impact on underlying medical conditions, and discuss the need for better sex education and education on sexuality. And then hopefully at the end, we'll be able to talk a little bit about preventative screening. I use traditional definitions when referring to intellectual disability as well as developmental disabilities. So adolescence is a time of rapid change and has been categorized into 3 stages: early, middle, and late. However, unlike early developmental milestones, adolescence doesn't have distinct defined milestones. So it can be a little bit harder to navigate and a little more challenging for patients and parents with disabilities when confronted with physical, hormonal, and psychological changes during this period of time. In the United States, the National Commission on Adolescent Sexual Health in 1995, and I'm going to summarize their statement, said that healthy sexual development is a basic human right, including the disenfranchised, disabled, and gay and lesbian adolescents. Teen intimacy ought to be consensual, non-exploitive, honest, pleasurable, protected against unintended pregnancy and sexually transmitted infections. And I wish this was what was really happening in the world, but we're almost 3 decades out from when this consensus statement was published, and we still don't have great sexual education. We still don't have great ways to help families navigate adolescence and how to understand sexuality and how we change through our lifetime. So puberty and developmental disabilities can also add some new layers to all of this and all of these changes that we're undergoing. Underlying medical problems such as a seizure disorder, for example. Seizures in women can be exacerbated in a cyclic or what we call catamenial pattern or cycle. And we'll talk about that more in a bit. Women who are on specific medications like antipsychotics for mood stabilization can have resulting side effects of hyperprolactinemia that affect their menstrual cycles. And women with intellectual disabilities may have a hard time communicating discomfort and pain. Women with developmental or intellectual disabilities may have a hard time managing their menstrual hygiene. And a lot of some conditions, particularly Fragile X syndrome, can lead to premature ovarian insufficiency. So having providers aware of these specific challenges are important when dealing with adolescents and women with developmental disabilities. So education is power and knowledge is power. So we need to start when we're young, learning the names and parts of our bodies, simple explanations of where blood comes from at early ages so that when menses do start, it's not a shocking or concerning problem. It's something, oh, I heard about this before. Girls who have sensory issues, start using pads and underwear before the period starts. Maybe buying period underwear so it becomes a normal process to put on period underwear and remove pads. Learning how to overcome challenges with limited mobilities and how to care for these problems. And then starting at developmentally appropriate ages and in language that one can understand, learning about sexuality and sexual health, gender identity, gender issues come up for people with disabilities just like they do for people without disabilities. So it's important to start talking about this stuff before puberty, through puberty, and as we get older. A good resource for parents is the parentcenterhub.org. It's a site that helps parents navigate the development of sexuality in adolescents with disabilities. It covers what sexuality is, its meaning in adolescence and adult life, and the responsibilities that go along with exploring and experiencing one's own sexuality. So when women come in and girls come into my office, I usually get asked 3 things when it pertains to periods. First is I have a hard time with the menstrual hygiene. I have cyclic or mood behavioral changes, things that happen every month that I just kind of don't know how to deal with. And then the need for contraception. And so what I would like to do in these situations is kind of get to know the person and their family and ask specific questions, trying to figure out what the main concern is, and so we can both kind of come to an understanding and figure out what we can do to best help this person navigate their periods, feel that they have control over their bodies and their reproduction. I also like to talk to the person individually about how her quality of life is affected by her periods. Are there specific situations where it is really hard to manage? Does she have specific concerns about pregnancy? What are her underlying health conditions? Should she become pregnant? What I've found is sometimes doctors and other healthcare providers will tell a young woman, you cannot get pregnant. And what the person takes from that situation is, oh, I'm not fertile, I can't get pregnant. But that's not necessarily the meaning. The meaning may be, you have a heart condition that will be really strained by pregnancy. It is not safe for you to become pregnant at this time. And so really kind of learning the underlying medical conditions is so important. And a great way to do this is something called shared decision-making. And shared decision-making is in many ways ideal for addressing issues that pertain to contraception and help with period problems. It allows providers to assess preferences around relevant issues such as effectiveness, menstrual changes, and use of methods. It can help you identify misconceptions that may be underlying why a patient might exclude certain methods from her choice. And it allows providers to tailor the information and discuss the patient's needs and ensure that all women have the information and support they need to choose a method that they can decide is best for them. And PATH is a nice an acronym for for questions designed to elicit and clarify preferences about reproduction and motivation about pregnancy and pregnancy prevention. So menstrual suppression and contraception, the first goal is always safety, safety in the choice, and then which option, as we discussed previously, is going to be best for the individual person seeking an option. And here I've listed several options. And at the bottom, you can see here endometrial ablation and hysterectomy. Unfortunately, with time constraints, I couldn't get into a lot of information about that, but these are permanent and often should only be done, if there is an underlying medical need or medical concern. So here is a great guideline for from the Center for Disease Control, and this is called the medical eligibility criteria. And this is just a little piece of that. Here on the column on the left, you can see the different medical conditions. On the top, you can see the different types of birth control. I stands for initiation, C stands for continuation. And then it has different, a number scale, 1 to 4. 1 meaning that there's really no limits, that birth control is completely safe for any given condition. 2 means that the benefits usually outweigh the risks. 3, the risks are starting to outweigh the benefits, and 4, real harm can come from using that mode of birth control. So these slides, the next several slides have a lot of information, and this all pertains to birth control. So first, oral contraceptive pills come in progesterone only versus estrogen and progesterone combinations. So the mini pill has been around for a long time. We often will use it in women who are lactating after giving birth. And it is 0.35 milligrams of norethindrone, a specific progestin, versus an off-label use of 5 milligrams of norethindrone. I will often use the 5 milligrams of norethindrone for my patients who cannot safely use estrogen-containing birth control pills and want to still use a pill. The 5 milligrams of norethindrone does suppress ovulation, and there's a little conversion through first pass through the liver from the progesterone into estrogen. Now, the next one that I talk about here is SLIND. SLIND is relatively new in the United States. It's been around for about 1.5 years, 2 years, so it's still brand name, but it is 4 milligrams of drospirenone. Drospirenone has been around for a long time in combined oral contraceptive pills in the US. It is equivalent at 4 milligram dose to about 30 milligrams of spironolactone. Spironolactone is an anti-testosterone at the skin level. It helps women, particularly with other gynecologic concerns like hyperandrogenism, to slow down unwanted hair growth. It doesn't prevent it, but it can help slow it down so that a woman doesn't need to wax or shave as often or pluck hairs that are unwanted. However, you do need to make sure that you have good underlying kidney function because spironolactone is also a weak potassium-sparing diuretic. Other options are combined oral contraceptives. The 2 types of estrogen are ethinyl estradiol with a varying dose range, and then minestrol, which gets converted to ethylene estradiol in the liver. There are 10 different types of progesterone commercially available in combined oral contraceptive pills. And they were each developed at different times, trying to mitigate some of the side effects that women didn't like in taking those pills. So when I prescribe a birth control pill to any woman, I try to take in her concerns and things that she is trying to achieve with her pill, and I pick the best one. I let her know that, you know, it's not a one size fits all. That's why we have 10 different types, and every woman reacts a little bit differently to hormones. So if it's not working for her, I want her to let me know immediately so we can try something else. Combined oral contraceptives also come in monophasic and multiphasic regimens. The monophasic are better for menstrual suppression in that they have the same amount of estrogen and progesterone in each active pill, and it can be used in an extended cycle. So what that means is instead of having 3 weeks of active medicine, 1 week of a period, you can continue to stretch on the period-free weeks. Some pills come in packages that have 84 active pills, so you have your period about every 3 months. Others are up to a year. How do birth control pills work? They work at the ovary, stopping ovulation. They decrease the ability of the fallopian tubes to sweep an egg in for fertilization. They thin and stabilize the lining of the uterus, thicken cervical mucus. They also increase the P450 enzymes within the liver and increase sex binding globulin, which can also decrease androgens that are circulating, and in some women decrease their sex drive. These are all important things to talk about. So what about combined oral contraceptives for women who spend a lot of their time in wheelchairs? Unfortunately, we don't have a lot of good data to help us out on this. So a thorough family history is important. I make sure I ask about things like underlying clotting disorder, such as factor V or prothrombin gene mutation. And then the first line would always be considering a progesterone. And then if a progesterone only method isn't really gonna fit for this patient or person, I start thinking about the lowest dose estrogen that I can do to help achieve the goals that she wants from her contraception or menstrual suppression. Now, I will say that women who have had quadriplegia through childhood have been shown to have reduced what we call venous lakes, and therefore we think the stasis within their bloodstream is less and may have less of a lifetime risk for DVTs or venous thromboembolic events. Unfortunately, I don't have any really good studies to draw on for this, so it's something I really try to communicate with my patients. Next, I want to talk about the patch. It is a continuous release system over 7 days of both estrogen and progesterone. Recently, we've been finding in pharmacologic studies that the estrogen concentration can get as high as our 50 microgram combined pills. And with sustained levels at this higher estrogen within the bloodstream, we have had more venous thrombotic events. So it is no longer recommended that you use the patch in an extended use. They are nice because you can place them anywhere on the body except for the breast. It is a sustained release. You don't have to remember to do it every day or take the medication daily. Its mechanism of action is the same as for birth control pills, but women with sensitive skin might find that they have a local skin reaction. The vaginal ring is another sustained both estrogen and progesterone releasing method. And the concentrations don't seem to get as high as with the patch. It can be removed for 3 hours in a 24-hour time period and up to 48 hours without a need for backup contraception. The complaints are often around vaginal discharge, unexpected bleeding, and very similar to other combined hormonal methods. It's also important to know that only water-based vaginal medications can be used because you don't want to impede the absorption of the hormone through the vaginal mucosa. Now, women with developmental disabilities might find this one a little challenging on how to place the vaginal ring in the vagina and remove it. Privacy may be an issue. I have had some couples where the partner is able to help place and remove the vaginal ring. Next, I want to talk about depomedroxyprogesterone. In the United States, it's used most often as a 150 milligram intramuscular injection. It does also come in a subcutaneous version. Amenorrhea, or no periods, is achieved after pretty well after a year, but the longer we use this medication, the more it seems to have decreased bleeding. Benefits are it seems to act as at the GABA receptor. It's likely converted to allopregnanolone, which is a neurosteroid that acts at the GABA-A receptor. It can stabilize the red blood cell membrane for patients with sickle cell and decreased crises. And it's really a good medication to use for endometriosis pain. My big concern is the bone density. Anytime a woman has a low or hypoestrogenic state, I start to get concerned about her bone health. And estrogen stimulates the osteoblast to build bone and slows down the osteoclast. Bone is always in a state of turnover and remodeling to keep it strong. So my patients who spend most of their time non-weight bearing or are also on seizure anti-epileptic medications, I talk to them a lot about this, encourage calcium and vitamin D, and any type of weight bearing exercise they can do to help build bone strength is important as well. The etononorgestrel implant is a single rod that goes under the skin subcutaneously, most often in the non-dominant upper extremity. For some of my patients with intellectual disabilities, we have placed it in between the scapula to avoid picking and potentially self-removal. It's effective for 4 years. The medication has a short half-life, so once removed from the body, the hormone is out of the system within about 24 hours. Counseling is really needed with this implant for bleeding patterns. 20% of women will achieve amenorrhea, 30% will have lighter periods, and the rest have random to sometimes everyday nuisance bleeding. However, it is the most effective form of birth control we have. It's more effective than a vasectomy. Next, I'll talk about the intrauterine systems. There are 4 that are commercially available in the United States. 2, Mirena and Liletta, are getting FDA approval for 7 years. The other 2 have 3 and 5-year approvals in the US. IUDs are great at helping decrease menstrual flow, help with menstrual cramps overall, and they can be placed in patients who have not had children. If the patient is a young adolescent, she needs to be at least 2 years out from menarche or initiation of menses. Otherwise, I get an ultrasound because the uterus needs to be about 5 centimeters for successful placement. Now, adolescents may have a higher rate of expulsion. Women with intellectual disabilities, once the IUD is placed, they may have a hard time letting you know that they are having cramping. You can have cramping for up to about 2 weeks after placed. And so that's something to let the families know about and potentially use just around the clock Motrin. And for a lot of women, my patients who have cerebral palsy, contractures, those type of things, I will often use sedation either in the office or in the operating room to help make the placement more comfortable as well. This is just a summary of the types of birth control that we just reviewed. So now epilepsy is a common neurologic disease that can be exacerbated in women, and that is called catamenial seizures. There are 3 patterns of catamenial exacerbation around the time of ovulation, right before menses when there's a fall in progesterone, and if a woman is anovulatory and without hormonal medication and she has higher levels of sustained estrogen. Estrogen is thought to increase neuronal excitability by increasing terminal axon production of NDMA or N-methyl D-aspartate. And progesterone is thought to be a potent anticonvulsant by getting converted in the brain to allopregnanolone and working at a GABA A receptor at an affinity greater than that for benzodiazepines. These are some of the studied non-hormonal medications for seizures. Unfortunately, there isn't a ton of studies in looking specifically at catamenial seizures. We are seeing more of this though, which is very hopeful for the future. The things that have been studied the most is progesterone. In particularly one that overlaps with birth control is Depo-Provera. And then there's a synthetic analog of allopregnanolone, which in trials has shown to have good improvement in catamenial seizures. The biggest cause for discontinuations have been dizziness, fatigue, and somnolence. When working with a family and a person with epilepsy, I like to start with norethindrone, simply because there is some conversion to estrogen to help with bone health. At 5 milligrams, it can work as a contraceptive as well. Combined oral contraceptives can affect a lot of seizure medications. So over here, you can see the decrease efficacy of combined oral contraceptives by these different anti-epileptic medications. These anti-epileptic medications on the right don't have any effect on the efficacy of the birth control, but lamotrigine and valproic acid can have their levels lowered if a person is on combined oral contraceptive pills. All right, so switching gears again, sexuality and disabilities. If one of the biggest myths is if sexual education is taught, then they might get ideas, or that people with disabilities, they're always supervised, or they don't have an opportunity to engage in sexual activity. These are things that I think we really need. It's misinformation. And I think that this is an opportunity to both educate caregivers, the patients, and the UN in 2006 came out with a statement enforcing these ideas that sexual health is important for all people. And then educating the parents is often the first barrier, if you will, to be overcome. And I often start around the time of puberty. And so when a young girl starts to get breast buds, that means her ovaries are activating. She has about 2.5 years till her period. And that's a great time to start educating parents about puberty, what it's going to mean in their lives, also about sexuality, and that, yes, they still have a child, but their child can grow into a sexual being. And again, these are some resources for parents. Also starting with my patient at the time of puberty, making sure she knows her body types, slang where appropriate, differences between public and private spaces, how babies are made. All of these things are so important in addition to good communication skills and self-assertiveness. And again, it's repetition. We all need to learn something several times before it really becomes a part of who we are. So as a Gen Xer myself, starting to use things like YouTube and other electronic avenues has been a great help. Since they weren't available when I was learning, and I've adapted as an adult, thank goodness. And then parenting for protection, because particularly with my young patients with intellectual disabilities and who cannot communicate or advocate for themselves all the time, it's so important that they learn at whatever level they're capable of learning, and that the parents are a big proponent of that. Something that can be started young is the No Go Tell program. And this is a really good way to help kids learn that, yes, it's their body. And if they don't want someone in their space, it's okay to tell them no. And lastly, I just want to advocate for preventative health screening for all people. Women with disabilities still need the same healthcare screenings, sexually transmitted infection testing starting with sex, Pap smear starting at 21. Sometimes I need to kind of change how I deliver this care. I'll often work with my colleagues in dentistry to provide Pap smears and pelvic exams under one anesthetic. And it's just really important that we recognize the need for preventative health care for all women. So today, I hope you have learned a little bit more about puberty and adolescents with disabilities, some effective ways to help suppress periods, and then that behavioral changes are common in all adolescents, and there's always a good way to help maneuver through that time period. And education, education, education. Thank you. I will unshare my screen. All right.
Great, thank you so much. Would you like to take questions now or wait until after?
I'm happy to do either, however we think will help the flow. I'm happy to do questions now. I want to see what everybody else wants to present too, so I will still be here at the end as well.
Okay. I have a question that was texted to me.
Okay.
And it is for people who are, there's a lot of women that are affected by SMA that will take the pill that takes them off for 3 months at a time. And so they don't have their period for 3 months. So the question is, for somebody that is on that type of contraception, what are the negative long-term effects of being on that?
Well, so I always like to start with the positive. So the positive is that it decreases that woman's risk of uterine and ovarian cancer by 50%. So that's great. Does not increase her risk of breast cancer. Does not change her fertility. So there's a myth out there that if you have extended use of birth control, that you might become less fertile in the future. That is also not true. One thing that we are finding more in studies is that ethinyl estradiol, which is the common estrogen in these extended use pills, doesn't work as effectively on bones and bone health. So my concern would be bone health in this situation. And so it's just making sure you're on a good calcium supplement and vitamin D. I live in upstate New York where it's often gray. We have long winters. You live in Canada, very similar weather. So I recommend higher levels of vitamin D, around 2,000 international units, or getting your vitamin D levels checked to make sure you're getting adequate vitamin D.
So would that be a concern then for somebody that is wheelchair bound and typically with SMA, very fragile bones, very not dense, translucent even. So is that something they should avoid?
I don't think I would avoid it. I think it's something to be aware of and to try and do other mitigating things like the calcium and vitamin D. A lot of times, if I am following these patients long term, I will get a DEXA scan to see what their bone density status is. If their bones are really thin, like in the osteoporotic range, compared to age-matched controls, then I sometimes will recommend switching to an IUD. Because that works locally. IUDs are not systemic birth control. The progesterone effect is just actually within the uterus. It does not stop ovulation or natural production of ovarian estrogen. So that's a good alternative for women who have bone health concerns related to contraception.
Okay. many with SMA also have low iron.
Mhm.
So that, you know, that's one of the reasons they are taking these pills so that they don't have their periods so
Yeah.
often.
And that's why the IUD is such a great option, is it has really good amenorrhea rates. You know, about 80% of women will have no period over the 6 years, to 7 years that a progesterone IUD is good for.
And that over extended period, like many years, is not going to be a problem.
No, it's not. Your natural cyclic estrogen is still being made. So the ovaries are still producing estrogen and progesterone. What the IUD does is it keeps the lining, which is where the period is every month, from growing. So once it's stable, the cells of the lining of the uterus kind of come off like natural skin cells and will come out through the discharge in the vagina. So it doesn't have any negative effect to not have a period. And I often tell my patients, I've had an IUD, I'm on my third one, and I've had a handful of periods the whole time. And it's just a great form of contraception and a great way to not have systemic hormones to interfere with other medications, and to not have excessive menstrual bleeding as well.
And the type of IUD that you would recommend?
A progesterone IUD, a levonorgestrel IUD. There's from the slides, there are 4 different types that are commercially available.
Okay, thank you. Does anybody else have any questions? Just unmute yourself and go right ahead and ask.
There's no bad questions. I love talking about periods and birth control. I love it.
I have a question.
Yeah.
I was wondering your opinion on the best birth control for a patient with SMA and PCOS.
That's a good one. So PCOS is polycystic ovarian syndrome, and it is associated with hyperandrogenism. So you can get unwanted facial hair, acne, those kind of things. So that's tricky. D, because it wouldn't affect the bones. And then to help with that, the skin level hyperandrogenism, I often will prescribe spironolactone. It is a weak potassium sparing diuretic, so I have to make sure that her kidneys are functioning appropriately. But that also helps with the acne, unwanted facial hair, those kind of things. So she'd have good birth control, wouldn't affect her bones, and the spironolactone helps with the acne. Now, if she's really hesitant to have something in her body and doesn't want an IUD, my next favorite is now the drospirenone, 4 milligrams. That drospirenone is an analog of spironolactone. It's equivalent to about 30 milligrams of spironolactone, and it can have good anti-testosterone effects as well. You have to be aware it's a progesterone only that stops ovulation. So the bone health considerations are still there, but in one oral contraceptive, she could get help with the PCOS, not have an increased risk of blood clots with estrogen containing birth controls, and get help with the hyperandrogenism as well.
All right, thank you.
Yeah.
Anybody else have a question? All right. Then we will move over to Dr. Tepper. Thank you so much, Dr. Nicandri. Will you be staying around?
Yes, I'm happy to.
Awesome.
Yes,
Okay,
pleasure.
so if anybody has questions at the end that they thought of, then that'd be great. Or you can also put it in the chat too, and we can answer it later.
Perfect.
All right, thank you. Okay, Mitchell, it's all you.
Hi, I'm Dr. Mitchell Tepper. I'm a human sexuality educator, researcher, and coach. I'm a wheelchair user, secondary to diving accident. So I have a incomplete spinal cord injury in my neck, which affects my hands and um, somewhat my mobility. So, I bring to my work some personal experience with both disability, chronic condition we won't get into, but also a PhD in human sexuality education. I'm going to share my screen now. So I was asked to share a few slides. And can everyone see my slides now?
Yes.
Let me get them into a speaker mode. Still with me?
Yes, all looks good.
Oh, it's good, except for oops, we're starting at the end instead of the beginning.
Except for that.
Except for that. So, I was asked to speak about men's sexual health. And big topic. And these were things that come to my mind when someone asked me to speak about men's sexual health based on issues that people come to me with. So one, getting and keeping an erection, pleasing a partner, ejaculation, fertility, masturbation, porn, masculinity, and then pleasure and orgasm. So these are the type of things that I'm going to cover. And I've been working with all types of disabilities and chronic conditions over the last 30 some odd years. And whether I'm familiar with the condition or not, I always go back to the literature before I speak with a group. And I went to the literature, and there's like Zippo for men with SMA on men's sexual health, on sexuality. I even went to basic research. So I'm going to speak somewhat in general terms, and then hopefully there'll be questions that I could address for specific issues. So getting and keeping an erection. Getting an erection and keeping an erection is primarily about blood flow to the genitals. So we get an erection when our increase in blood flow results in erection. And keeping an erection is a complex mechanism of what goes on with the arteries and the veins. So the erection basically maintains itself with healthy tissue, but that could be a problem for people with different conditions. So one, getting an erection also relies on proper nerve function. And so one thing I gathered from the literature on men with SMA is there's a much greater percentage chance of having erectile difficulties, which we call ED or erectile dysfunction, than other people. And sometimes people get some erections, but they're not there when they want them. They're not able to keep the erection. So I will talk a little bit about mechanisms or medications. And fortunately for men, it's a lot simpler than women, and hormones and menstruation and birth control. So there's like 5 categories of medications and solutions that I'll share with you. And then people are often concerned whether they'll be able to please a partner, because jumping down to masculinity, there's a lot of media focus on men being able to perform and to fulfill certain roles and to be masculine and to be able to please their partner. So men of all ages, but especially young men, are often worried about pleasing a partner. And I'll have to say, women are worried about pleasing a partner too. So these things are not exclusive to men, but I wanted to include it here. So next is ejaculation, right? So men, as they're growing up, sometimes are concerned if they have wet dreams, if they're ejaculating at night. Men are concerned if they're not ejaculating yet, as maybe some of their friends are, but they haven't ejaculated yet. And so that has to do with your maturity and your hormones as you go through puberty. And then there are people who are ejaculating and they're concerning about the quality, the quantity, how far it goes. And then fertility, which could be tied to ejaculation, because obviously not obviously, but if you cannot ejaculate, then you wonder if I could ever have children. And so when we look at fertility, there are other ways to get at the sperm, which is responsible for fertilizing the ovum or the egg. So if even without ejaculation, there could be what we call assistive reproductive techniques to help get a partner pregnant. But fertility also has to do with the quality of the sperm, how well they swim, and the quantity of them, but it only takes one. So I was not able to find really any information about sperm quality and if it's affected through different types of SMA. So, I invite you to ask questions, and we'll do the same. So, masturbation, as once again for men and women, not just boys. If people are masturbating, sometimes they worry about, are they masturbating too much? Or maybe they're not able to masturbate at all. So some people's hands functions, their ability to reach. I know with women, sometimes they have an inability to reach their genitals to be able to stimulate themselves effectively. So if your muscles are weak and you feel like touching yourself and sexually stimulating yourself and you can't, what do you do about that? And so that, there's a whole area around what we call facilitated sex or assistive sex. And you basically are negotiating with the helper to help set you up for masturbation, maybe with some kind of device that makes it easier, or maybe by putting on something on the screen that's sexually stimulating. But if you cannot stimulate yourself, and because of that, you don't know whether you could get or keep an erection, and you don't know whether you can ejaculate, because I have a lot of men with other developmental disabilities who come to me in their late 20s and 30s with all these questions, and it's taken them 30 years to get the nerve up to come for help. And so we want to help you answer these questions as soon as they arise for you. And we might say, what does porn have to do with men's sexual health? Well, I would like to say we learn about sexuality, at school and from our families and from our healthcare providers and our houses of worship, but that generally is not the case. And unfortunately, porn has become the primary sexuality educator of people, at least in the United States. It's very accessible, and it provides one of those images of sex, taking what you see in the media and going to a different level. So what we learn from porn is not accurate, but also more importantly, people are accessing porn, and more they're coming to me, almost everybody I speak to, wondering if they have a sexual addiction. So that's a broad question and a topic that's very controversial in the area of sex therapy. So I was a certified member of the American Association of Sexuality Educators, Counselors, and Therapists. And we don't endorse a addiction model, but we talk about out of control behavior. And so, but many people are just looking at porn maybe an hour a day or 2 hours a day and wondering if they're addicted. And that's not necessarily an indication. So the time you spend looking at pornography is not necessarily an indication of a quote unquote addiction. So if you're spending inordinate amount of time, a lot of time, and that time is causing you to not fulfill other obligations, if you're getting into trouble spending money on porn, there's a lot of negative consequences that could come from watching porn, but infertility isn't one of them. Going blind isn't one of them, because when we talk about watching porn, we're often combining that. We're talking about masturbation. So there's a lot of misinformation about the negative outcomes. But if you think you're watching too much porn, then you need to speak with somebody about that. But very rarely do I find someone who fits a description of either typical addiction or what we would call compulsion or out of control sexual behavior. Normally, it's a normal outlet for people who really have not found another outlet for their sexual expression, right? And so it's not necessarily harmful. It's not what I recommend for adolescents. I recommend adolescents learning about sexuality from reliable sources. I know we were talking about people with developmental disabilities, and both for adolescents and adults, I like to limit their sexually stimulating material to magazines and taking people off the internet, because the internet is a place, if you don't know what you're doing, you could end up, coming across things that are upsetting, some things that will stay with you in your vision, in your mind, and also could get you in trouble if you start looking at images of underage people, and could get you into serious legal issues. But I needed to put porn on this list because in my regular, coaching, and no matter where I go, it comes up. And so, talking about masculinity, right? As people with disabilities, often we can't fulfill those roles that are put forth as masculine roles, right? Sometimes it impairs our ability to earn, right? And so sometimes we think a masculine role is to provide for our families, right? Or the masculine role is to protect and to open a door or to do things. Now, over the years, these roles, we think are changing, and there's a lot more flexibility in gender expression, but these, let's say, historical masculinity, femininity type of attributes are still alive and strong and create a lot of tension and a lot of distress when you can't fit either of the roles. So, as a sexuality educator, we like to embrace both the masculine and feminine within each person and look at the positive aspects of both masculinity and femininity. And if you cannot fulfill one of the traditional roles on either side, does not make you any less of a man or a woman, or any less of they, or anything you care to, identify as, so, we're looking, as I think, as a culture, both probably in the United States and Canada, of breaking away from traditional gender roles. But, we'd be lying to ourselves if they aren't a significant influence on people's feelings of themselves as they go through puberty, as they develop into sexually healthy adults. And then the last thing here on the list, as a general overview, is pleasure and orgasm. So as a sexuality educator, I've avoided in my career, although I deal with it, but I didn't get specifically involved in sexually transmitted diseases or sexually transmitted infections or HIV or unwanted pregnancies, or even issues of sexual abuse, which is unfortunately extremely high amongst men and women, both men and women with disabilities. So, I've done research studies to quantify how high that is based on national databases. And, for women, they're forced to have penis and vaginal intercourse at a greater than 2 times the rate of women without disabilities. So women without disabilities, and this is how they talk about it in the surveys, forced to have penis and vagina intercourse. So that's that's the most strictest definition of rape. And 15% of women in the general population in the United States between the ages of 18 and 55, which we call the reproductive age, have been raped. And in women with disabilities, that number is a little over 30%. So, that's, I've stayed away from those things, because outside of the abuse amongst people with disabilities, the other stuff, there are plenty and plenty and plenty of great public health professionals, great human sexuality educators that are working day in and day out at those problems. There are very few people who focus on the pleasure that people with disabilities have and can get, and helping those with disabilities and chronic conditions optimize their pleasure. My goal is to help you take pleasure in your sexuality so that sexuality isn't a cause of distress. It's not a source of emotional pain for you, right? And how we do this is, one, when I'm working with groups of young folks with disabilities, any kind, SMA included, the number one thing I tell them is you have to become more educated about human sexuality than any of your friends. And that means reading really good books, maybe getting a human sexuality textbook, and learning from reliable sources about sex and gender and how your body works. Because when we understand how our body works, and we understand, this thing called orgasm, right? So it's talked about and it's held out as like the end all and be all of a sexual engagement. And orgasm is great, but many people think, well, if I can't get an erection, if I can't ejaculate, well, I can't have an orgasm. Why bother even engaging in any sexual activity? Number one, you don't need to get or keep an erection in order to experience orgasm. Orgasm is a euphoric feeling, a feeling of release, feeling of bliss. It's been described in many different ways, but it's what we call a brain-mediated event. And I can't get into that, but part of my research has been laboratory research on orgasm in women with complete spinal cord injury. So women who have no feeling or movement below their level of injury. And we've documented in a lab that they have the ability to experience orgasm, and did brain studies using MRIs and looking at brain activity during stimulation and during orgasm. And so, if I were able to, well, I have a picture up on my wall back there. There's a picture back in the screen there, and it's a blow up of the EEG during masturbation, which shows the changes in the brain. So orgasm is a brain mediated event, and I believe it's accessible to everybody, no matter what the disability. So pleasure and orgasm, I think, are the reasons that most people have sex and sexual activity. It's really not to have a baby. People generally do that between 1 and 12 times in their lifetime. So, sexuality is about relationships and, having a special connection with somebody. So with that, we're going to get into just a few more specifics. So I told you we'd get into solutions for erectile dysfunction. So if any young men or older men listening to this are concerned about their ability to get or keep an erection, you should talk with your physician, whether it's a specialty physician or a general physician. All physicians that are able to prescribe medicine can prescribe oral medication. Susie, can I mention name brands here?
Yes, absolutely, you can.
Some people are concerned about using name brands, but many people have heard of the little blue pill or Viagra. So that was one of the first oral medications that you take, and it helps increase the blood flow, as I mentioned, to your genitals to help you get an erection. And then other medications have come along, sildenafil, and I could go on and go on. One is sildenafil. I don't even remember the Levitra. I don't remember the brand names now because I'm so used to calling them. But the Viagra and the other oral medications for getting an erection, you can ask any physician who could prescribe. And the next and these aren't in a, they're a particular order of, well, let's say least invasive, but pumps are another solution. And some may put this one first because it actually is, it's not, you don't take a pill that affects your whole body. Pumps, and I put the word pumps here, we call them vacuum erection devices or VEDs. And it's a cylinder that looks like this, that goes over your penis, and you press a button and it creates a vacuum, which then draws blood into your penis. So this will make any penis, no matter what the condition you have, increase the blood flow. And then there's a constriction device that goes around the base of this and slips on over your penis to keep the blood. So I said getting an erection is about getting blood in there and keeping it in there. So there's a vacuum erection device, and these are actually available without prescription, but I would recommend going to a doctor or other health professional to help you choose one that's of good quality, that has some, backup so that you don't hurt yourself, because, you can get some bruising if you keep it on and keep the vacuum on and don't know how to release the valve easily. So, and then for people who get an erection but can't keep it, we use constriction devices. Once again, I use the word cock rings because that's how you might find them online. But any device that's going to wrap around your penis in a way that's going to hold blood in, and you want to, there's precautions, because if you put this around there, you don't want to put it on there and fall asleep, because you don't want to trap blood into your penis. It's not flowing back and forth. So that could have very negative outcomes. So you want to get a constriction device. You want to make sure you use lubrication, because we're worried about skin integrity, because we don't want you to get a skin breakdown on the shaft of your penis. And we want you to be able to use it safely. Set an alarm if you think you might have sex and fall asleep, because we don't want to just trap blood in there that's not able to flow. And then although pumps are second, people often go to injections of medication in the penis if pills don't work. And so once again, this is the model of a penis. There's injections of medication into the side of the penis. Some guys are really scared about this because the idea of putting a needle in their penis freaks them out. But actually, there's not a lot of nerve endings there, and it doesn't hurt that much. A lot of the guys I work don't even have sensation, or they have diminished sensation, so they don't feel it at all. And they're still concerned about putting a needle there because it just freaks you out. But once you get used to that, it's a very reliable way for a lot of men who aren't reacting to a pill to get an erection. The thing about constriction devices and pumps is that they keep an erection from where they are. And so your erection may go like a pendulum. An erection through medication actually comes from underneath your scrotum and is firmer. So some people don't like about the pumps a pendulum effect, and sometimes because you're keeping blood in there and it's not circulating, the penis could feel cold. So sometimes if you're with a partner, they prefer the warmth of a penis that's not as hard versus a harder penis that's cool. So it's an individual and often a couple decision, even on using any of these medications. Your partner may say, okay, the pill is good enough, or the pump, because I can't. Some people need help from their partner doing the injection or putting on the ring, but the partner might rather put a ring on you and use a pump than inject a needle into your penis, even though you say, I can't feel it, it doesn't matter. And then last, if all else fails, and if you want an erection, we have devices that we could implant. So this is one of the more popular devices. And your penis actually has two cylinders inside it. and these would be implanted into your penis. Right now, they're flaccid. There is this valve that would be implanted into your scrotum, right? So my hands don't work so well, but that's in there. This is implanted into the scrotum, and you could reach through the skin of your scrotum to activate this and create an erection. And there's a third reservoir of liquid. So instead of blood going into your penis to cause an erection, I think it's a silicone fluid that they keep in there that will flow in and out. So from the outside, you know, you're getting an erection. It looks like any other erection. It stays there as long as you want. It's good for satisfying a partner. Generally, we don't recommend them for young men because over a long time, they may what's called erode. They may, you know, that implants may push through the end of your penis and then they have to be removed and replaced. So it's not something that's recommended strongly, but if a man wants to, and that's their choice, and they know what the risks are over the long time, then, you know, I believe in, you know, the patient's choice. Excuse me. I just clicked and it didn't move forward. There we go. So for people with neurological impairment who aren't able to ejaculate, there are specialty vibrators. One is called the Vibrect. And what we've learned from using regular vibrators in men with neurological impairments is most of this has been done in men with spinal cord injuries and multiple sclerosis, is that sometimes two vibrators are better than one. So generally, when using vibrators to stimulate or elicit an ejaculation, we're doing the frenulum, the underside of the penis here. And we would take, this is the second vibrator called the Ferticare. So it's a medical vibrator now available without prescription, but it's still quite expensive. I think it's in the $700-800 range. But these are all very powerful vibrators. They have something called a rheostat or an adjustment. And that affects, if you could hear it, it affects the frequency. The lower frequency, a higher frequency. And it also affects what's called the peak to peak amplitude. If you could see my finger, it's really moving a lot here. So it's sometimes kind of brutal. But those two combinations of frequency and peak to peak amplitude in a medical vibrator is what makes the difference between an over-the-counter vibrator and in the ability to elicit ejaculation from someone with nerve impairment. So this one is really noisy, and I'm going to try to hold it right there and squeeze. When it's not squeezing, it's really loud. And so these are devices that can be used to stimulate or elicit ejaculation in men who are not ejaculation because of a neurologic issue. So I'm not exactly sure if this is applicable to SMA, but you can ask your physician or your doctor. So this is really I think the most important, and this is both for men and women, is that the position of your mind is more important than the position of your body, right? The feelings in your heart are more important than the feelings in your genitals, right? And the quality of your connection with your partner is more important than the quality of your erection. We found this to be true not only in spinal cord injury, but when I say we, I have some colleagues in Canada that look at peak sexual experiences for people of all ages. And no one talks about the quality of their erection or how much they lubricate or how far they ejaculate. People talk about a connection, a yearning for connection, and this kind of connectiveness that they have, and all the different words they use for their great sexual experiences, and none of them really focus on the quality of the erection or lubrication. So that's number one. You know, I told you in the beginning, this is a brain-mediated event. Even pleasure is a brain-mediated event. Something may feel good when it's wanted, and touch may feel bad when it's not wanted. The same touch, right? So context matters. And when I say context matters, in the study, and we studied women in the laboratory on orgasm and spinal cord injury. Afterwards, I studied men and women who both had the experienced orgasm and didn't. And I studied, what was the difference? Why was one person experiencing this and another? And whether people had an orgasm or not, I asked them about a peak sexual experience. And they said I needed to be with someone I trusted. So that context of trust and safety, feeling safe with, and not just physically safe, emotionally safe, because having sex with somebody else is a very vulnerable situation. We literally take our pants down. We're literally naked in front of somebody else. So it's we're vulnerable in many ways, but we're vulnerable emotionally for getting hurt, right? And so if we're not sure of how we're going to perform and we're worried about it and we're not with someone we trust and it goes wrong, we're not in a safe place. But when there's trust and safety in that relationship, and this is true, I've taken classes on sexual trauma and recovering from sexual trauma, and although trust, safety, and connectedness came from my research on pleasure and orgasm with spinal cord injuries, this combination of trust and safety is important for trauma survivors. I believe it's important for everybody. It's obviously not in every hookup. People will meet somebody and have sex with them right away and have pleasure and orgasm, in a short-term encounter. But we're talking about relationships and longer-term relationships. And so this trust and safety led to a sense of connectiveness. And I believe we all yearn for connection. We want someone to love us as a total human being, which means it's nice to have a best friend. It's nice to have parents or siblings that love you. But we want someone to love us as a sexual person because that represents our full humanity, right? And so trust and safety leads to connectiveness, and connectiveness has the ability to transcend any physical loss. So whether you can't move, whether you have hormonal issues or whatever. So trust, safety, and connectiveness is an important container for a healthy sexual relationship. And then the next thing I talk about is stop, focus, and connect. So we have to slow down, right? So people are often rushing into sex and their minds are busy. So we have to learn to slow down our thinking. We have to learn so that we're not overly anxious when we get into a sexual situation. We need to begin to focus, which means setting a proper intention. This is going to be, we're going to get together and we're getting together for mutual pleasuring, right? And then we have to pay particular attention both to what's going on in our body physiologically and to our partners. And then we connect. We connect through communication. We connect through looking at each other's eyes. We connect through breathing, right? And often I recommend people take a course in mindfulness. So there's been more research lately, and I've been teaching something called accessible tantra, but in the psychological literature and in generalized treatment, people are recommending mindfulness. And so mindfulness is about being in the moment and about being aware of what's going on in the moment and trying to stay there. So when distracting thoughts come, we let them go. And so I recommend people get a mindfulness app and work on mindfulness in general outside of their sexual life. And then I also recommend that people take an accessible yoga class. And it doesn't matter if you cannot move at all. The yoga I take, and I think the essence of yoga is on breathing. And breathing naturally and deeply and freely is very important to sexual arousal. So if we take mindfulness classes and we take some kind of online accessible yoga class and we learn to breathe, right? And then we take those skills and apply them to a sexual situation where we have an intention for mutual pleasure, and we're going to pay attention to what arouses us, we are going to have great experiences. And lastly, and I hope I'm not going over here, for logistics of sex, how do I do this? I'm in a wheelchair. I can hardly move myself. Someone else has to help me move. I need help with my bowel and bladders. How am I going to ever have sex? Who's going to want to have sex with me? There are three things, and they're written right here, that are the fundamental basis for all the logistics of sex: creativity, adaptability, and a sense of humor. So we need to be creative. We need to be able to use our imagination, and we need to be able to use our creativity and imagination to find ways in which we could find pleasure for ourselves or mutually with the partner, right? Adaptability, something we as people who either grown up with their disabilities like you all, or me who's acquired my disability, but I've had it almost 40 years, probably longer than most of you, have learned through our life to be adaptable. We can't be afraid to take those same skills that we are excellent at and put them to our sexual lives. So, and lastly, a sense of humor. Sex sometimes could be, out there in the media, it's this fun thing and everything, but it could be anxiety provoking for many, and it could get us down if it's not working properly. But if we remain a sense of humor and we understand that everyone has hiccups when it comes to sexuality and sexual function and response, and that the end game is not orgasm. It's about mutual connectiveness. It's about taking pleasure in who you are. We all have value just from being born on this earth. That's my kind of religious, philosophical perspective. And we are all born sexual beings, and we all have a right to sexual pleasure, no matter what anyone else tells us. So you need to be your own advocate. So if your parents aren't talking with you, if your doctor's not talking with you, if you're not getting information, if your partner is avoiding you, you need to advocate for yourself and say, listen, I've been having a lot of thoughts about my sexuality. I really want to find ways to explore it, either with myself so I know what's going on, or with somebody else. And that is what you have to take into your own hands, because unfortunately the health system generally isn't going to do it for you. And I do want to make a plug. Coming up on October 20th through 22nd, I am co-chair of the second annual Love Abilities Virtual Sexuality and Disability Festival. Last year, we had 650 people sign up from around the world over 5 days. This year, we took it back to 3 days, but I've got folks from Canada involved in planning, and folks from the UK, and folks from the Philippines. And it's for and by people with disabilities. It's very accessible. We offer, free attendance without any application. You just say, I can't afford it, and you could come. If for 3 days, I don't know what it is, $27 to $30 US. So it's very accessible. And if the time you sign up and the time isn't good, all the recordings will be available for 30 days. So this is a good start where you could learn about sexuality the whole first day, 7 hours on relationships. The second day, whole day on logistics. And the third day on everything else, like, getting help with sex and getting sexual help written into your financial planning for your disability. And we have like people from 3 different countries who, their countries have supported that. So that's where we are. Unfortunately, our third speaker, Dr. Shapik, will not be with us today. And so I am happy to answer any questions about relationships too, because I help people, write their personal, their things for their apps, for their online dating, and help people examine what characteristics and what qualities first that they have to share. And so we got to bring out the most positive characteristics, and then what you're looking for in another person. And often people want to know, should I disclose my disability? And so we could talk about that and the different answers to that. So I'm happy, Susie, to field any questions that people have about meeting a partner or dating logistics or moving it from friendship zone to a sexual relationship. These are the kind of things that young people with disabilities and everybody, deals with. But, as people with disabilities, we have additional barriers and additional things that we have to deal with that the general population of other people don't have to deal with. Thank you.
Yeah, that was great, Mitch. Honestly, a lot of what you said is applicable to women too, the mindfulness and the mind position, keeping a sense of humor and being aware. Could you give me a link at some point? Can you email it to me for that October 20th to 22nd session? Then I can send it out to
Loveabilities.org, and you could sign up to be notified when tickets go on sale. We have a Facebook group with over 500 members from last year. So it's a wonderful place to share information during the year.
And we can share that on our social media so that
And so when you sign up for loveabilities.org, you also get to be a member of our Facebook group. I think anyone could go to Loveabilities, the general Facebook group, and then you have to be a participant. And like I said, we'll give free membership or whatever, free access. But when you then sign up to be in the conference, then we let you into the group, just so we don't get people who aren't, are spectators there that shouldn't be there.
Right. Does anybody have any questions for Dr. Tepper? Just unmute yourself and go right ahead and ask.
Yeah, maybe I'll go ahead and ask Susie. Thanks very much, Dr. Tepper. I really appreciate your presentation. A little discouraged at the amount of adults with SMA that have attended this session, because in my experience, sexuality is a huge issue for adults with SMA. And one question that often comes up is around the role of caregivers around masturbation.
Mm-hmm.
And what are your thoughts on that?
Well, get more specific. Are you worried about caregivers being police and not allowed?
It's more that comfort level. Obviously, it's a really personal thing. And I know in my case, I've had a long life, so I had my needs met in that way, but for a long time, it was a real challenge in talking to caregivers and having them set up. But I know many people with SMA don't have the dexterity in their hands, so they require assistive devices to have them set up for their pressure time. And some caregivers are good, some caregivers find it awkward. I'm just wondering what your perspective on that is.
So, and are you calling from Canada?
Yes.
Okay, so it's different from place to place. So I often talk to people about negotiating with their caregivers to give help. They're already helping with your bowel and bladder and very intimate things, right? So, and I'm always an advocate for advocating for your needs. And I would argue that this is a need just like anything else, right? But the realistic flip side of that is, especially if you have a caregiver who works for an agency, they're worried about all these legalistic things, right? So if they touch you, is that going to be considered that they're abusing you? And so policies either are not clear from the agencies or they're against it, right? So sometimes a caregiver will have to break a policy, right? Policies are not laws. So when policies aren't working for you, then you have to advocate for changing. But if your primary caregiver, the ones that you're working with closely, feel they can't do it, I don't think we're in a position to force them to do that. But we can look for an extra caregiver. And when you hire them, so I recommend when you're hiring a new caregiver and you're saying, these are your responsibilities, I need help bathing, dressing, brushing my teeth, feeding, and with self-stimulation. And this is what I need. I need you to set this up. I need you to clean up after me, and it's, so if you have these discussions, you'll find that more people are open to it than you think.
Great, thank you.
Keep asking.
And what about assistive devices for somebody that's got very limited movement?
Yeah, so
for men or women?
right. So starting with men, so it really depends. So it depends if you could strap on a vibrator and get a long one, right? Or if you have enough to hold, I'll just use this as an example, and the battery cover came off. But there are sleeves, like vagina sleeves, right? So you stick your penis in something like this, but it's got a much more soft and pleasurable inside. And so if you can hold a device like that and go like this, if you could get your penis in there, then that's a device that works. There are, and this is more, I want to say more appropriate for women, because generally us as men, we like more pressure. But I'm putting on this device here, which is a little vibrator. So if you can't hold a vibrator, and this is specifically, you can use this on yourself, right? But it's not that strong. But you can, if it depends, if you could get your hand there, you could fasten a more strong device. But I like this one particularly. I could turn it on with my head, so I don't need any finger dexterities. It's got different speeds. And so, or, if you learn to get pleasurable sensations from your nipples, you could stimulate your nipples, your air, different parts of your body, your collarbone. So different levels of vibration could cause sensations in your whole body. So masturbation doesn't always have to be of your genitals, right? And so for women, just putting this over their vulva, and if they want direct clitoral stimulation or around it, as long as they could get their hand there, this works really well. Or if you're with a partner and you want to lie on your side and you don't have the hand dexterity, you could put your hand over your partner's vulva or on their nipples or wherever. They feel both the warmth of your hand and the vibrations. So this is where the creativity and adaptability come in. So essentially there are sleeves, there are vibrators, but we also have to put our mind in it. I know another guy, I was just doing a panel, and a friend of mine, Hector, he talks about how aroused and even orgasmic he gets in writing erotic literature and having phone sex. So, and I've worked with young men with CP who cannot reach their genitals. They have spastic paralysis, who can't use their hands, rod in his back, so he can't even see, doesn't know what's happening. But he's gotten to the point through watching porn and sexual erotica that he could get off with just visual stimulation. So when we masturbate, we sometimes focus on our penis, but if we can't reach our penis at that time, then we could use a combination of fantasy, maybe finding a partner that you could write erotic stories to, or have erotic conversations that could get you very excited. With enough excitement, adding stimulation, maybe, like I said, sometimes it takes a while to develop sexual responses to extragenital stimulation, but it is absolutely possible. If you have an open mind and you attune, see what sexual arousal is. It's an increase in blood pressure, in respiration, in blood flow. So areas of your body feel warm. We talk about sex flush. These changes cause your hairs to stand on and your nipples to get hard, right? So if we could learn to tune into those and know that those are sexual arousal, just like a wet vagina or a hard penis, we could keep going with what feels good, use our breath. And I didn't mention sound, but sound is like, if you have privacy and you could use sound creates vibrations. Vibrations move. Now we're getting into the esoteric sexual energy through your body. So this is, I believe that we have, an energy body, and Eastern medicine looks at the energy body, and it survives even when the physical body doesn't, so, and, I do workshops where for example, have people shake their hands and stop, and they could feel the vibrations beyond their body. And when you get close, you could feel the warmth before you touch. So that shows that we have energy that expands beyond our body. And so if we could learn to move and play with this energy, this sexual energy, it can move and it can release and create great emotional feelings, right, from that. So we don't have to be stuck if we can't do that. But back to helping people helping you, whether it be a paid professional or a friend. At this point, we have to negotiate our needs because we can't force them on somebody if it's against their value system or if they're worried about repercussions from an agency. It's much easier to do when you hire somebody on your own, so that's why I asked about your funding source. And once again, I recommend including that when you're hiring people. So if you got somebody who doesn't see you as a sexual person, you can say next.
Thanks very much, Dr. Tepper. I just a few points I can add. You mentioned the point about devices. There are some out there as well. I've done a lot of research and they're not very easy to find, but there are devices that actually can be used if you have no hand function, so that they actually do the suction and the stroking and don't require you to have your hands.
Yeah, so
And also they do exist.
absolutely.
They're very costly.
Yeah.
And the other thing as well, if I can recommend to people, is working with your rehab team. I know in my case, my partner and I weren't able to have intercourse because of some fractures in my hips, but my occupational therapist set up a vibrator that had an adaptive control that I would be able to control the pressure of my heart.
I'd love to see a picture of that or even video. If you could share that, that'd be.
Yeah, it's really easy. It was just a basic vibrator and then attached a microlight switch to it. So I would just tap the switch and it would turn the vibrator on and off.
Okay, yeah. And there, I even mentioned that there are now so many vibrators that you could control through your phone, right?
Yes.
So a lot of the newer vibrators, they have a million functions. They're little tiny buttons. You turn them on, you want it off, you can't, you don't know what function you're on, but they have beautiful apps. And so even if people are using a power chair and not their hands, and they have a device to interact with their phone or computer, they could control their device or their device that's on their partner through whether it be eye gazing or using some kind of a stick or something to use their iPad or their computer to control the vibrator. So that's where we could use our creativity to use the stuff that's out there to do it. Yeah, I actually tried a device like you're talking about. There's a big pump and it was like a vacuum thing, but it pumped and stroked. I don't know if it was Venus for men or the Venus is the product for women. But this is one of the benefits of being a sexologist and going to a lot of conferences. People send me all kinds of stuff to try. And there's a new device to hold vibrators called Handy coming out of Canada. And you just HANDI, search for that. They've got a big web presence and they've been doing a lot of marketing and build up. And really within the last month, they showed the device. So you could actually, this is a device that's the size of your body that you could cuddle with. And on the bottom of it, you could put a vibrator in. That's what I'm getting from the pictures. And so you can lie on your side and just put a vibrator in there. And that creates, a very long handle.
Like just to reference the device I was talking about, excuse the vulgarity, but the device that I found has worked the best. It's called the Auto Blow.
Yes, I know it. I haven't used it, but I've seen it. So that I throw that in the category of sleeves. So you don't have to move it yourself, but you.
Right. This one provides the action as well.
Yeah. Thank you for offering that. Thank you for speaking up, being the representative for all males with SMA today. I was looking for somebody, and then yesterday, right on my LinkedIn page, when I signed in, there was a guy who's a LinkedIn influencer who does like employment stuff. And he came up on number one on my page, and I sent him an email. I'm like, I'd like to talk to you before I do this workshop tomorrow, but unfortunately I didn't hear back from him yet. So thank you.
I see you didn't even need them. You did fantastic.
Well, there were some things I wanted to know. I couldn't assume that SMA,
Yeah.
based on what I was reading, affects what it does hormonally as far as how it affects sperm genesis. And so, I don't want to pretend I know when I don't know. But
Well,
I would be
I
happy to do a survey of all your members and find out.
We can absolutely, I'm going to be sending out a survey at the end of this conference to get feedback on the different presentations and what people would like to see and what they did appreciate and all that. And we can certainly put in some questions from you as well. I just, I appreciate the openness and the honest questions and answers, because they're not the only, whoever's asking questions is not the only one that's wondering it. There's so many people that are wondering. I've had so many parents ask me questions, and if we're ever going to be putting something like this on so that they can have answers for their sons or their daughters. I guess a question that I'm hoping that you have the answer to is people, with the mindset of the kids as they're becoming teenagers and sexually wanting to be interactive in the community, how to get them over the step of fear of stepping out there and being recognized as somebody that has needs and wants to develop relationships and all the aspects of those relationships.
Is this forgetting the parents over the fears of having their kids out there, or the kids out there?
Well, it's definitely both, but we care about we want to give that information to the teens, that how to get them mentally over that step where they can feel.
I'm going to start with the parents though. So what I find is that parents want to protect their kids, and you mentioned it, Katrina, right? As far as parents want to protect their kids. They love their kids, right? And they want to protect their kids primarily. Of course, they want to protect them from sexual abuse, but they also want to protect them from heartache, because sometimes they feel like their kid doesn't have that potential to get married and to have children. And so they don't foster that. They foster the academics. So you'll find in the world of disability, where I travel sometimes, a lot of disability scholars, really, really bright people, because they've been focusing on the development of their mind and their scholarly skills or some other skills, because they haven't been encouraged. So I see a difference in folks, and it's in the literature, folks whose parents encourage them to be sexual people and to get involved in dating and et cetera, assume that that's possible for them, and they go after it and they're more successful, right? If your folks have been denying that or not nurturing that, then you're going to think maybe that's not an opportunity for me. And the same thing goes for health professionals. I've talked to people, a guy with quadriplegic who, they gave sex education in the hospital to other people, but not him. So he just assumed, oh, it's not possible for me. But that wasn't the case. So parents have to learn, and they have to, there's a boundary as far as protection and risk, right? And so for young people, I have to say that social media, this is controversial, but I'm going to say used properly has a net positive effect. So I've been disabled for 40 years, and I've been involved. I set up in 1996 a website, back when websites were the thing, sexualhealth.com. And I've watched the evolution of information online and social media. And if you go to Twitter, especially for young women, you will see loads and loads of young women out there proud about their sexuality, proud about whatever gender orientation they have, with body acceptance and body positivity, right? So I would say start to connect with groups that are around sexuality and disability, or just groups of other people with disabilities who are out there at the abilities, love abilities. We're going to have a young woman with osteogenesis imperfecta who's an actor in the UK, and that we're going to have a young woman from Louisiana who does like modeling, and we're going to have a panel. I was calling it body positivity. We might call it body acceptance. but we're going to have panels, people who are out there who are doing this. And so you need to find positive role models. They were very important to me when I was first injured. So you have to find your supportive communities that will help, nurture your sexual growth. And if you get, like I said, someone with a developmental disability, then they may need, a supervisor to help them. And there are other like dating sites that are geared towards more folks with learning impairments versus just physical impairments. And so, safety is an issue for everybody in the dating world. Getting your heart broken is an issue for everybody. And if you're a parent, your kids deserve the chance to get their heart broken. They deserve their chance to get an STD. I don't know. No one wants to really say that, but it's the right to take risks. As a person with a disability, don't take my right to take my risks away from me, right? So it'd be great. Every parent would think they'd like to be able to keep their kids from taking risks, right? But part of development is learning, and so that's what I would recommend is find groups.
And also the only thing that I would add to that is that I start talking with parents of children with disabilities at the time of puberty about their child becoming a sexual being, so that it's not a new thing if they walk in the room and they see their child masturbating and they don't know how to handle it, those kind of things. So I think it really becomes, educating with the parents first, realizing that sexuality is a normal part of human development, is a normal part of being a human. And we all have that, no matter what our abilities are. So just starting early with the parents, and also then hopefully they can role model, like Dr. Tepper was saying, role model normal sexual development too, and intimacy and things like that. Not necessarily in a watching your parents, that would be kind of too weird. But what I mean by role modeling is that saying that it's okay, that I encourage you to have relationships and meet people and, find a community in which you belong, because we all want that. I think that's just an innate human need.
And, in my research in sexuality education, counseling, and spinal cord injury rehab programs, the number one person people want to hear from first is their medical doctor. So I congratulate you for being so open and for preparing parents. And I would wish if every medical doctor did that for, kids with developmental disabilities, then I think the kids would be in much better, position for their sexual development. So thank you.
Well, I do it for half the population. I'm a gynecologist, so.
Yeah, good.
But I do have other colleagues in adolescent medicine who are doing an amazing job too.
I think for that, being a parent, and being involved with so many parents that have kids with SMA, as you know, people affected by SMA are mentally completely normal and have normal desires and wants and intelligence. And I think the restriction of parents is often part of the problem. And like you're saying, walking in on your child or visualizing that your child might be a sexual being is difficult. I think parents in this position have to get over that to be able to let their children feel like they are, and not just feel, but are a normal part of society in that way, and
that's
help them gain that access.
And that's where, like, just learning about adolescence and going through, how adolescence is such a time of growth and development that isn't just, about meeting specific, developmental milestones. It's about all kinds of brain maturation, learning who they are from gender identity and sexual identity and health, and all of these wonderful things that make us human and the capacity for being a human. And so it's really trying to, the thing that I find the biggest barrier is that parents have a hard time going from being a little kid. And someone who, when someone has specific needs and through their disability that the parent is always caring for and helping with as a primary caregiver, then seeing their child grow and become a sexual person is very hard because they get stuck. The parent gets stuck in seeing their child as a child, not as a young adult, an adult, and those kind of things. And so that's where I try to help the parents realize that your child's not a child anymore. They're always going to be your child, and you're always going to love them, but they're growing into an adult. And this is part of becoming an adult and what is so important. And I wish there was just more time built into, our healthcare system, and time is money. And that's just such a disservice to so many people. But it's really kind of just educating the whole family about your child's not just going to be a child forever.
And one other concern people have that I've heard is like, who's ever going to be able to take care of my kid like I do, right? So to imagine them actually moving out with someone else and the amount of care they might be, and to think that there's someone else in the world who's going to provide that for their child like they do is another layer of concern.
It's
And a lot of-
terrifying from a parent's
Yeah.
perspective.
And a
That,
lot of my patients have just the fear of pregnancy, that their
Mhm.
parents have the fear of pregnancy. And so that's where, shared decision-making with my patient is such an important thing, and what their desires around their reproduction and their reproductive health is so important.
Susie, maybe I can as an adult with SMA, the role that parents play is so vital. I think back to when I was a teenager, 30 years ago, the resources weren't available for families like they are today. When I was a teenager, I had caregivers through an agency, and teenage boy, I had my dreams. One day, my mother had a call from the home care agency saying that they would not be sending in any caregivers unless my parents made me wear a diaper to bed and put me on top of it. And my mother immediately, and I heard her say this is ridiculous. My son is a young man. This is a normal behavior. I don't want your caregivers coming into my house if you're going to enforce those kinds of limitations on my son. And from my perspective, because my mother took that perspective, it helped me become more of a sexual being.
There's an absolutely great positive example of positive
Yeah.
parenting.
yeah,
Yeah.
good for your mom. I mean, my goodness.
Yeah.
That must have been hard for you to go through, but
It was terrible, but at the end, it was a good experience.
yeah, thanks so much for sharing that, Jeff. Yeah, I guess does anybody else have anything to say? Because we're pretty much at time here. I cannot thank you both enough for coming and presenting, and for the attendees, and it's great that this resource is going to be there for the community to access anytime. We're going to have a link to it on the website and share the information on social media that it is accessible. I thank you so much for making a topic that can be difficult, comfortable, easy, and so much information for everybody. Thank you so much.
My
Thank you
pleasure.
for having us.
All right, have a great rest of your day, everyone.
Bye-bye.
Take care.
Bye.